Our next speaker is Dr. Demetria Sampson. Dr. Demetria is a 2003 graduate of Xavier University of Louisiana. She received a bachelor's degree of science in chemistry, and in 2014 she completed her doctorate of philosophy degree in pharmacological sciences with a concentration in medicinal chemistry at Florida A&M University. So that sounds like she's been to a few HBCUs, all right? Before coming to Xavier, Dr. Sampson oversaw the Florida Department of Health's Education and Ethel Moore Alzheimer's Disease Research Program and its advisory board. In addition to the FDOH Research Excellence Initiative program, the premier research training program for FDOH researchers. Dr. Sampson's research interests include central nervous system, drug development, particularly psychiatric disease, Alzheimer's disease, and dementia. And it is my great pleasure to introduce Dr. Sampson and ask her to come up to the stage.
Thank you. So as Dr. Turner just stated, my title is Ethical Issues Around Clinical Trials for Underrepresented Communities. So as we progress through this presentation, I'll go through a brief introduction. We'll look at the phases of drug development process, as well as what are clinical trials and what it involves, pertinent issues, ethical issues affecting underrepresented communities, looking at strategies to overcoming barriers, and then we'll conclude the presentation. So racial and ethnic disparities in health outcomes are persistent within the United States, primarily due to two things: inequities in access to and the utilization of healthcare services, as well as broader social and economic factors that reflect historic and ongoing racism. Given higher rates of certain illnesses among people of color, they could disproportionately benefit from medical advancements within clinical trials. Underrepresented communities face increased barriers to accessing new drug therapies and treatments due to lack of diversity in clinical trials and structural barriers, including financial barriers. These disparities in access to medical advancements may further exacerbate racial disparities in health outcomes and life expectancy. So as we begin to talk about clinical trials and what it involves, clinical trials is a part of a bigger process in which drugs or medical devices undergo development. Usually there is some discovery and development phase where you're going to look at particular targets within the body. That may be enzymes or proteins or anything of the like that the scientist believes has an implication on onset of certain disease states, ailments, or symptoms that you're trying to cure or treat. From then, they will develop an experimental protocol, and they will go into the preclinical phases where essentially you'll be doing lab or bench type work called in vitro studies, and then we have in vivo studies, which will be done in animals, so that we can kind of get an idea of how these devices or these therapies may actually behave in human subjects. Once we find our optimal therapeutic device or treatment, we have a good idea of its toxicology, we have a good idea of its activity, and most important, it did not kill any of the animals. Then we will place it into human subjects. In next section, we call it clinical research. From there, we would exhaust different types of human subjects and different characteristics and backgrounds. And if the drug still proves to be effective, or the therapy still proves to be effective, if it is safe, then we will then apply for approval for that drug. And your federal regulating bodies, which here in the United States is the Food and Drug Administration, they are going to review all of the data, all of the information that was collected, and if they find that the benefit of using this drug or therapy outweighs the risk, then the drug or the therapy will be approved. Once it's approved, it's open to everyone to use, whether they were included in those clinical trials or not. In this section, after that it is approved, we have something called post-marketing surveillance or evaluation. At that point, since the medication or therapy is available to the general public, we have to continue now to see its behaviors, if it's still safe, if it's still effective, because now we have people who are not included in the trials are going to be using this medication. So within the clinical research section, which I believe was the third step on the previous slide, it is a type of medical research that studies humans to understand health and disease. It helps improve the way doctors treat and prevent illness. It also assists researchers in learning. We want to look at how the body actually works, how illness develops in people in such a way that how diseases can get worse or better over time. Also, how the body handles a possible treatment and which behaviors help people stay healthy and prevent illness, and which behaviors raise the chance of illness. The overall goal in clinical research is to use science to improve people's health care and health over time. Participants who join and take part in clinical research studies may or may not get any benefit for themselves, but it will be able to help the scientists to understand how this therapy or this device will be able to behave in the overall population. So of clinical research, clinical trials is a type of clinical research in which researchers assign participants to get one or more interventions to test what happens in people. This is because of this, clinical trials are also called intervention studies, in which intervention is investigational. This pretty much means that it's not approved for doctors to prescribe. So since this is not a customary process or therapy or drug that's normally available for people, we have to see how it's going to behave before you can just give it to someone, right? In my research lab, I'm a medicinal chemist. We make structures all day, every day. In general, most times no one has ever made them before. But I just can't give someone my drug or my candidate that I've made in my lab, right, that I believe will be good for the prevention of Alzheimer's or dementia or schizophrenia without me having any type of proof or information. Research participants must meet certain parameters, which are called eligibility criteria, in which it provides details on who can and cannot join the study. Typically, these eligibility criteria center around people of a certain age or sex, people who do or did not have a certain illness, disease, or health condition. It's also centered around people with or without a certain health history, such as prior treatment already for this disease state or ailment or symptom that you're trying to cure or treat, as well as people who are exposed to or are in contact with something that affects their health. Researchers typically use eligibility criteria to keep the participants safe and enroll the right participants to collect data that they need to answer the research question. Since there are so many research studies that are involved in clinical trials, there's also many different types of eligibility criteria that a participant must meet in order for them to receive treatment. So clinical trials, we talked about as a part of clinical research. There are some primary phases that medical devices and therapies must undergo in order for us to understand what it's doing in the body and its safety. So typically, the therapy or the device is going to be compared to a placebo, which typically does not have any type of effect on whatever it is you're trying to test. Or it will be compared to an existing treatment that's already a standard on the market. There are 4 phases in which this will be done. In phase 1, you typically have less than 100 people or so who will be tested, and these are actually healthy subjects. These are not individuals who have the disease state itself. In this section, you want to test the safety of the medication or the therapy, as well as test for any side effects, and define what is the actual effective dose that is needed for appropriate activity. In phase 2, we have a larger sample size, which may be a few hundred up to 1,000 people or so. You're going to test for side effects in this case as well, and you want to continue to compare the medication from the existing medication or therapy to the placebo or existing treatment. However, in this population, these are individuals who actually have the disease state itself. And then when we get to phase 3, you're going to be in a few thousand, upwards to 3,000, 7,000 people or so. And you're going to have a much broader population of individuals who this therapy will be tested against to see exactly how it's performing, ensure its efficacy and its non-toxicity. Now, if a drug or therapy passes all of these states, we find out 2 major questions. It works, and it doesn't kill you, right? Then we're going to put in for an application for its approval. Once that's done, we submit to the regulating body, and they're going to review all this data. And once they provide that license or the ability for us to now prescribe the product or administer the product to the general public, then we're going to go into that phase 4 that I talked about before, where we have post-market surveillance, where we're going to continue to look at the long-term effects of using that therapy or that medical device. Now, in clinical trials, diverse racial and ethnic representation is important because drugs, vaccines, and other therapies can differentially affect groups due to variations in underlying experiences and environmental exposures. Access barriers, lack of information, and historic and ongoing structural racism and discrimination all contribute to the underrepresentation of people of color in clinical trials. When research only includes people with similar backgrounds, the findings may not apply or benefit to a broader population. The results of clinical trials and studies with diverse participants may apply to more people. That's why research benefits from having participants of different ages, sexes, races, and ethnicities. Now, this is just a chart that's comparing the population demographics from the US Census in 2020 compared to the participation of clinical trials of different racial groups and ethnicities in 2022. As we look here, we see in the blue that 60% of the population in 2020, from the US Census 2020, was white. We have here in the dark blue, 19% was Hispanic or Latinx, and then 13% was Black or African American, 6.2% was Asian, and this does include Hawaiian and Pacific Islander, and then we have 1% is Native American and Alaskan Native. However, when we look at the participation of individuals in clinical trials in 2022, we see that the numbers do not compare. When looking at whites, 80% of clinical trial participants were a part of white Americans. When we look at African Americans, only 10% comprise the participation of clinical trials in comparison to 13% of the population that we actually make up. We have 6% for Latinx and Hispanic community, and then there is 1% for Asian population, and less than 0.2% for Native American and Alaskan Native. This is alarming. Institutions such as Xavier University was founded for the education of slaves and Native Americans in indentured servitude. If this school did not exist, we would not be able to reach the tribal nations that we have throughout the state of Louisiana and Mississippi, as well as the Black community that we have throughout our state. So it's important that we have people who are aware, who look like us, to reach out to these demographics to ensure the proper and positive health outcomes that they deserve. So there are multiple levels of barriers of clinical research participation, in which there are 4 broad categories. We have an individual level, interpersonal level, institutional level, and policy level. In the individual level, factors impacting access to trials, both logistical and practical. This includes time, resource constraints, language and literacy, as well as caregiver constraints or responsibilities that they may be having. With interpersonal level, the patient and provider attitudes and beliefs, discrimination, bias and lack of awareness, and engagement. Institutional level, factors such as lack of trust, racism, competing goals, and eligibility criteria that may be so narrow that it does not include these underrepresented populations. And then we have the policy level, in which challenges with funding mechanisms. Just recently, we see the executive orders are trying to do away with DEI itself. The FDA has developed a guidance to improve and to enhance the diversity of the clinical trial participants. However, although having a guidance is good, it is not mandated. So typically, people who follow grants and programs from the federal government follow them very closely. But if you say that it is a guidance and not a mandate, we do not see much improvement since the employment of this DEI enhancement that was shown. So there are 3 broad categories in which our issues are broken down into. We have mistrust, accessing information, and participation in trials. So with mistrust, we have misinformation and misconceptions about clinical trials. Often people don't even know what a clinical trial is, which is why today I went through great details to make sure you are clear on what a clinical trial is. Some people believe that, oh, you're going to give me a treatment and I'm going to die. Or I can't get any additional health access or treatment if something happens to me. So we have to make sure that people understand what it is that they're coming into. What are they signing up for? That was one of the biggest issues with the Tuskegee experiment. A lot of African Americans believed that they gave the black men syphilis. It wasn't that they gave them syphilis. They did not provide them treatment, even when treatment was available. So you're looking at your loved ones die. You're looking at your loved ones in torment and the issues that they're going through. So that then will cause me to not have faith in my federal government, to not have faith in the healthcare system. Even today, we have African American women are dying from childbirth at 3 times the rate of our white counterparts. When we go to the doctor, they're not understanding when we're saying, hey, we're in pain. I have experienced that myself. And I'm just coming as just a normal patient. And my doctor or whoever is seeing me is like, oh, you'll be okay. It can't be that bad. So then I have to put on my Dr. Sampson hat. Hey, I'm Dr. Sampson, by the way. Can you please do A, B, C, and D? And if you don't, I need you to chart it in my report that I asked you and you refused. Then everyone starts running, right? Once you actually put that on, but I'm just a regular patient. And so these things all lead to the mistrust that we have and to decrease the participation of underrepresented communities. We also have a research community that does not acknowledge these past injustices. Often people will say, oh, that was so long ago, it's not a big deal. Oh, that won't happen here. You shouldn't worry about that. But they don't actually take the time to listen and understand what their concerns are, what is happening, right? But these previous biases that they may have will really shift the treatment as well as the outcomes of those patients. When it comes to accessing information, you have limited or low quality internet access. I think when COVID hit, that was one of the things that reared its ugly head because we could not go into school or work, but yet these children are expected to jump online without any help, right? Pending that they have internet at home. Or we'll say we're going to move to virtual appointments. Well, do they even have a computer? Do they even know how to log in without anyone explaining these things to them? Also, lack of awareness on locating clinical trials information, as well as resource transparency and materials in multiple languages. In this group, sometimes people have never heard of a clinical trial. I don't even know where to get the information from. When I go to the doctor tells me there's nothing else that they can do, and they're not providing me any additional information. And so from that alone, our people are not having the ability to just know, to be aware, to gain access to improve their health. We also have access to information from trusted resources and materials that connect with diverse communities. One of the biggest things is making sure that we have socially appropriate information available, making sure that it's in the proper languages for those populations, and not just to translate. Because often people may take a document written in English and just translate it, instead of actually having a local jargon to where it makes logical sense to the reader from that descent. So things like that will hinder the patient from understanding what information you're presenting to them and what it is that they're getting into. We also have participation in trials in which we have limited diversity of trial doctors and staff. One of the biggest things that we see is that there are not enough of underrepresented principal investigators and researchers. Without them, how are we to relate to the people that we are trying to serve? So often, if this particular person is treating me in such a way, I don't trust you. But if they see me, they're like, you know what? I'm going to the homegirl. She all right. I'm going to talk to her. Right? My dad used to do it all the time. If you're not talking to him right, he don't want to deal with you. But he's looking for the person that looks like him. I need a brother. Yeah, the brother is my doctor. That's what he would always say. That is important for us to be able to reach to the people in the language that they understand. Also, making sure that there's a lack of compensation for child care and time off work, lack of health insurance coverage, and use of technology in trials. With these, often people have time restraints and financial barriers to where I have to go to work. And if you are laying out your clinical trials from 9 to 5, and I can't get off work, if I take off from work, I'm going to get fired. What am I to do? I want to participate. I want to get additional health care, but I can't because it is not in the time restraints that will be allowable for me. The same thing with transportation, being able to get access there. There's something called decentralized trials, where people are now placing clinical trials from, let's say, an urbanized area to more rural areas or in more burdened communities. But if those locations do not have proper training, proper staff, and proper resources, then you have participants out here who are hanging out on their own. But then if we don't have those locations and it's only located in the urban areas, then how am I going to travel from my rural community to the city? Often they will provide a voucher or some type of reimbursement, but we need more than just a reimbursement. What if I don't even have a car? Or I don't even have the resources to front that money for me to even get reimbursed back? These are major issues that are preventing underrepresented communities from participating. So there are some strategies to increase diversity in trials. You can build inter-community relationships, engage in trusted spaces, and create community recruitment sites. All three of these will increase trust, increase participation, as well as community partnership. You may also address personal bias, offer flexible scheduling and minimize hidden costs, and commit to workforce diversity. Just to talk a little bit about addressing personal bias, there was some studies before that was done during COVID time. And there are some researchers who believe that African Americans' lung capacity is larger than anyone else. So here they are doing research on respiratory diseases and then coming up with some random calculation to correct for what they believe is the increased lung capacity of African Americans. That hinders us, right? This is slated data that is not accurate, is not ethical, and it definitely does not maintain integrity. How is that going to help us when so many of our people contracted COVID-19? So many of them had long COVID. Also, some additional ways to increase diversity: it is support inclusive protocols, invest in communities, offer mentorship and employment experience. All of these will enhance recruitment partnership, community support, infrastructure, as well as representation and research leadership. And then we also have policy and society diversity strategies in which we can increase research funding, address systemic racism, and introduce inclusive health policies. This will provide equal access to care, as well as innovative therapeutics and health equity for all. In conclusion, clinical trial participation has not appropriately represented all patient populations, which risk overlooking all patients' perspectives and potential health outcomes. When research only includes people with similar backgrounds, the findings may not apply to or benefit a broader population. The results of clinical trials and studies with diverse participants may apply to more people, in which research benefits from having participants of different age, sex, race, and ethnicities. And that concludes my presentation. Oh, okay.
We'll have a little discussion.
We can have a discussion.
And we're going to open it up. I want to open it up for questions. Dr. Sampson, you said a whole bunch. but it's so important, right? Because it seems like oftentimes ethical considerations seem to be the last thing that people talk about. And we had an opportunity to talk a little bit about your time in Florida. Mm-hmm. So I would like you to share with folks kind of what you saw down there, what you experienced, and things that we should all be aware of when we're thinking about public health issues.
Okay, well, public health issues, I'm a hardcore scientist. As for my training, I'm a medicinal chemist, in which I'm an organic chemist. I make paper towels and plastics. But another medicinal chemist back there, all right. We're very, few nerds around. But I'm a hardcore scientist, that's it, right? So when I worked for the Florida Department of Health, it was one of those things where I had to jump into public health, and I became a public health scientist. I oversaw all of these research programs for the state of Florida, as well as for the division of Department of Health. And to understand the people and the issues that were coming before them, to sit in town hall meetings and to understand what was going on, it made what I did in the lab much more important. Often you have people who, like in Florida, you have a huge populations that do not speak English. And so, especially if you went down to areas of Miami, Fort Lauderdale, certain parts of Orlando, you will walk in, there's nothing in English. And you have to then find someone who speaks English to check you out the store. That was my experience. And it was one of those things where they go to a health clinic and they're not able to communicate with the provider. So we have a translator there. The translator, if they have some personal affliction with the person, may not tell or translate everything to the provider. And that was an issue we were experiencing, because they would know the doctor, and they would know that the doctor didn't really care for certain things or didn't want to work towards certain things. So we had people who would report these things to us. So now we have to put together clinics, right, of different universities and medical schools and pharmacy schools of different backgrounds to go into these communities and to deal with them, to really understand what is happening, right? We had certain areas where we had high rates of HIV transmission, and we had it to the point to where we would, there's something called GIS. I don't know much about it, but they would really go all the way down to the zip code for us to figure out the different strains of HIV virus that was mutating and who had the highest amount in what area to help us to prevent any other contractions of the disease. And you're talking to people and they're like, what do you mean? I don't know what's happening. I don't know what's going on. And you're trying to let them know, hey, you have HIV. Hey, you have full-blown AIDS. And they don't understand anything that you're saying. They understand nothing. So it was one of those things where I had to learn, okay, what do we need to do for us to explain this to people? We had to understand the ethnic backgrounds. One of the largest populations was Haitian population. It was very taboo, apparently, for them to even talk about sex. So then you had to disguise it in different ways. I had to learn your jargon. I'm a pure New Orleans native. I know nothing about Haitian anything. A little bit of Creole I know is full French, that's it. But it was being able to understand because they did not feel comfortable talking to some of the providers. And so I always say if you are any type of person dealing with the people, you need to understand the people that you're dealing with. You need to understand what their concerns are. You need to understand what their needs are in order for us to improve not only their health, but just themselves as a person. Those basic needs, those basic necessities that we tend to overlook.
So when we talk about ethical work, especially when we're talking about black men who, as we spoke before, are least likely to participate in these studies or these trials, you know, we have IRB standards, we have government standards, but what, as far as you're concerned, what do you think the things that we as researchers, scholars, clinicians, what are the things that we need to make sure that we have our internal compass directed in the right way so that way we are not, you know, part of the problem too?
I think one of the basic things that you need is to make sure you have people on your advisory boards and as your men, black men on your advisory boards and as your consultants. So I know throughout my time at the Department of Health, we have very few men and even less black men or men of any type of minority background. So, but we're making decisions, right? So these people are coming, you have committees, they're making these decisions, and then they're going to present it to some assistant for a Florida senator, right? Or a congressperson there, you know, or they're going to bring a lobbyist to you who wants to advocate for something, right? For them to get funding or for the state government to change or federal government to change something. But the very people that you're dealing with, you don't even have as a person to even reach out and ask questions to. So I think that's one of the most important things is to get men on your consulting teams and on your advisory boards. The other thing is to make sure that you eliminate your personal bias. So often, you know, men sometimes, I'm not a man, but I do see, sometimes it size people up or they may be uncomfortable about showing their vulnerable side or the most sensitive side. But if they understand and, hey, I'm here to help you. I'm your brother and I'm here to understand whatever it is. There's no judgment here. I think that will be one of the biggest things as well that's going to allow for, hopefully, an increase in participation. And then also, whatever woman is in their life, whoever their partner is, often you're pushing that person to go to the doctor. Even for women, your partner is pushing you. And they're going to keep nagging you until you do it. And so being able to bring in, I guess, the familial side of it may be able to essentially inspire them to kind of come and participate and learn more, at least become more aware.
Thank you. We're going to open it up for questions. I know there's a microphone out there, but before they do, I just want to speak a little bit. I want you to speak a little. When I saw those slides up there of all the different stages, 4 different stages, It scared me. I ain't gonna lie. You're like, we want to make sure the animals didn't die. Well, I don't want to be an animal and it didn't die. It didn't me, right? Like, what? Why should I, as a black man in particular, you scared the heck out of me. Why should I get involved in a clinical trial?
I wanted to make sure that you understand that researchers go through great lengths to protect you. Because it's not just you who's taking the medication or participating in this therapy, it's me too. It's my loved ones, right? There's an old adage that says no one cares about your research but you until you apply it to them. You have to apply it to them. No one thought, oh, AIDS was just for, individuals who are lesbians and gays, right? Until a straight person got it, right? Or their cousin got it. No one cared about cancer. No one cared about COVID-19 until they got it or a loved one got it. And so we have to figure out how to tap into that personal touch to relate it to them to make sure they understand how important it is. Because in general, people just don't care.
All right. Do we have the microphone out there? All right, we have a question over here, please.
Hi, thank you so much for that. That was very informative.
Name, please. Name.
Oh, sorry. It's not on?
No, we can hear you.
Oh,
Tell us who you are.
Oh, sorry. Dina Darlington. I'm with Linked Equity. I'm the founder of Linked Equity. So, question. You showed a chart, a graph, too.
The U.S. Census 2020
Yeah,
and clinical stats for 2022.
exactly. Do you have a sense as to why you had that decrease in participation after you had, a higher number or a higher percentage, and then maybe 2 or 3 years later, it dropped? Do you have a sense?
Well, actually, the first chart was showing you the demographic of the population in the United States according to the U.S. Census. And then the second chart was actually showing you that same demographic's participation in clinical trials in 2022. So the most optimal thing, in order for you to have most accurate data, is that you would want participants in your clinical trials who represent the population demographic. So if you have 13% African Americans in the U.S. population, according to the most recent census, and for us it's 2022, then we would like to see that same number in our clinical trials. Often, these clinical trials are being tested on populations that didn't even participate. And as I stated before, once it's approved, everyone gets it. So I don't know how it's going to behave in you. I don't know how it's going to behave in you. And people will complain. They'll say, oh my God, that drug isn't working. We don't know what's happening. I'm not taking it. Well, we didn't have anyone from that population to get tested in the clinical trials, which makes the post-monitoring so important. And that's usually when our underrepresented communities actually get evaluated is during that time period. And so, we want to make sure that when we design our studies, we design our trials, that they are representative, that they do correlate appropriately. Because people will sometimes draw information from just Medicaid data, or they'll draw information from Medicare data, or they'll draw information just from these 10 people to make a generalized comment or decision off of that. But that's not the most effective way to do it. And it doesn't give you a clearer vision of what's actually going on. So.
Al Hathaway, I'm with the African Ancestry Neuroscience Research Initiative. What strikes me is that you went through a whole rigorous ethical approach to clinical trials. Mm-hmm. But we're in an era where at the highest levels, there are going to be questions around even ethics at the highest level of government. Mm-hmm. So I just wonder, it's baked inside of the rigor, is it policy or is it law? When you look at how do you conduct a clinical trial, is it that this is the policy by which we do it, or is this the law by which we do it?
So you actually have both, all right? So Don't quote me on all the laws. But there are laws, both state and federal laws, to regulate how research should be done or who can participate and how you can share information, how you can recruit information. Typically, your IRBs, the institutional review boards, are pretty well abreast about, what those regulations are. And so when you submit to do this research or have this particular clinical trial, it's the responsibility of the institutional review board to make sure that you're within those regulations and laws. Now, outside of law and policy, you have your personal integrity. With that, there is nothing wrong with you designing your studies in such a way that is more inclusive, regardless of what they're telling you on the policy and law sides for your state and federal regulating bodies, as long as you fall within the range. Sometimes it's not just about what they say, it's about what they don't say. And so if you're able to figure that part of it out, you will be fine. But you have to take due diligence to do such a thing. Some people, they don't really care about the minority population. Oh, they'll be okay. This should be enough, right? But for us, we care. You care. That's why you are here. So if you take the time to figure out how you can still achieve those goals within those parameters, that'll be the key.
I feel like I got the voice of authority up here with me. Who else? Where else? Where else do we see a hand, please?
Thank you. My question, I guess you alluded to it, and again, I'm looking for the subconscious behaviors, and have there been clinical studies of why your dad or other gender, even myself, I walk into a hospital, I want to see the brother versus not seeing him, versus when I walk into a classroom, I'm teaching STEM or engineering, why it clicks better with my young black audience versus a Caucasian man walking in the same way. So I'm imagining, has there been a clinical study on cortisol flow versus dopamine flow? When I walk in, okay, I know your mama, so now we cool, the dopamine flows, versus I don't know you, cortisol flows, so I'm gonna step back. So has there been a clinical study on that, is my question.
Actually, yes, there are some clinical studies that look at that. So one thing I didn't talk about outside of, so you have two types of clinical research. You have observational studies and clinical trials. I didn't go into details about observation studies because that wasn't our focus, but essentially looking at those behaviors and those responses to understand what's what. There is many sources that confirm, right, the importance of having someone that looks like me or that I can relate to and is direct correlation to their health or just their life expectancy, their life achievements, and so forth. And so often, right, just for me, just going somewhere, whenever I go to a conference or go wherever, I'm always looking for a black woman, honestly. And if there's not a black woman there for me to relate to, just to sit next to or just have community with, I'm looking for any minority first. And I'm being very honest with you, right? Because you assume, right, or believe, and this is our personal bias, that they may have like customs, right, and ideologies to you, like experiences. So you don't want to be the outcast, right? You want to be in community. I can trust you a little bit more because I believe that you understand this a little bit better, even without not having any data on it. That is our assumptions. And so we need continued studies. We need those studies to be louder, right? Because some people believe that we don't need all of these people out here in this audience to advance the population, right? To advance our country, to advance the world itself. And so we can't have a monolith because we aren't a monolith. We can't do that. So it's important for us to have it.
getting at the subconscious. Everything that you've said has been said before. But if I want to add some value, knowing the human mind, like stimulation of something increase, I'm imagining there's a financial imprint on teaching this education over a 2-year, 3-year period. And I'm thinking if somehow in this conversation that can be attached to how much money we're going to save in the future. Again, forethought for the future self. I think along with all this information, and when you add the money tag, of course, human mind stimulated by the love of money, that will attach, right, the dopamine to what you just said. And it'll be more favorable because now for my future self, if I do this, I'll be saving some money, X, Y, Z. Again, I'm just here.
So, so as I said before, there are studies that look and see what parts of the brain lights up for different types of satisfaction is what I think you're trying to explain, right? And so with it, that does include health, right? So what makes me want to run and become a vegan versus someone else? How does that contribute to my satisfaction and reward, right, that I feel? Whether that's an increase or a decrease in glutamate, dopamine, or serotonin, it depends on the person as well as the study that is done. But there are studies, I don't know any off the top of my head, but I can get those to you afterwards. But there are studies that have done that before, which is why you see the guidances and information that's saying, hey, we need people like us, people that represent the entire population in order for us to move the needle on this side.
Which is why we have an emerging scholars program. Haley, that's right. Go ahead, give it up. Haley, I think we have another question. All right, is there another question there? We're about going to wrap it up pretty soon, but we have another question. Okay.
So I need to ask this question carefully. Because I really was enjoying that dialogue just now and about research that's done. So first of all, thank you for the presentation, Dr. Sampson. And it's so great to see a black woman medicinal chemist sitting there. One of my first unofficial assignments when I became the associate dean in our school of pharmacy at the PWI that I work at. We had one young lady who was struggling and trying with everything she had to finish her PhD in medicinal chemistry. And it wasn't because she didn't love science. She's a rock star as far as chemistry was concerned. She tutored people, but it was being the only, right? And you're talking about representation. Thanks be to God, she did graduate. I got to hood her, right? And she still says, Dean Brown, if it wasn't for you, I don't know, I probably would have ran out of here screaming. And I'm getting a little emotional about it because I know that there are other young ladies and young men of color that are in these PWIs and they're the only ones. And so I don't know, I guess my question to you is I don't know what your story is in terms of that, but you went to a couple of HBCUs, so I'm imagining that maybe you weren't just a cohort of one, but you may have been in that field. But how important do you think it is for that representation to find community when you were, by the way, she is the first one to graduate from the University of Pittsburgh, first black female in the medicinal chemistroll program in the School of Pharmacy. Yeah.
That's wonderful. So for me, it is highly important. Throughout my time as a undergrad here at Xavier, I'm a local native, so for me, coming to Xavier is like the 13th grade, right? You knew everyone that you grew up with, everyone was here, so the support was always there. You kind of took it for granted. I didn't have to search for it. I didn't need to look for it. It was here, right? I stayed at home with my parents. I lived the best life ever. Everything was great, right? So then when I moved to Tallahassee, Florida, for Florida A&M University, although Florida A&M University is an HBCU, it is still difficult in STEM divisions to find many African Americans, men or women, within your divisions. That's just what it is across most STEM disciplines in this country. And so for me, my PI was a male. He just, in his mind, I didn't realize that he was trying to tell me he didn't want me in his lab. But I'm always so bubbly and, oh yeah, I'm going to be in Dr. Lavender's, you know, just so excited. But in hindsight, I think back on it and it was like, man, he was trying to tell me no, but I was so persistent. And so then when I got there, he was very adamant in showing me that he did not want me. In my division, it was only 2 women, students. That's it. All right. And so one, she failed out, and then it was just me. And it was all men of different backgrounds. Most were minority population, actually, but none that were African Americans at all at HBCU. And so I didn't have anyone to talk to when things were going awry, when it was getting difficult. All of my male counterparts, the postdocs, they were like, oh, you're so pretty. You got a beautiful smile. You should go and be a journalist and get on TV. That's what they told me. They told me that I should just quit and let this go because it's not for me. And so that was difficult, right? And I had to push through it, but I had no one to talk to. My friends, you know, they were all in different backgrounds. It was just me and another friend that we were both scientists. And we struggled, right? Because you're going in uncharted territory. And so we really leaned on each other a lot to get through it. And, you know, the others, they were, I think, business majors, so their concerns are a little bit different. Your friends are trying to figure out, your parents, why are you in school so long? I'm working on a PhD in medicinal chemistry. If I can't make a drug, I'm not good, right? I can't be a medicinal chemist. And so I say all that to say, you have to have some type of community to me, or some type of support, regardless of how that community is established. I like to play bingo. That's my thing. When nerves get bad, I enjoy bingo. I'm usually the youngest person there, but that's my community, right? So it's important to have that, to give you that outlet, allow you to be vulnerable, and allow, you know, support you and build you and say, keep going. Here at the College of Pharmacy at Xavier, we have over 70% female students. But the interesting part about it is that they all come from different backgrounds. And they don't come to me about class. They'll say, I want a review about, you know, a test or some notes. But then they begin to tell you about their personal problems and things going on in their life. And it's very difficult sometimes as a faculty member because I'm an officer of the university. I must report certain things, right? Certain trigger words or situations. And I'm not trying to be your friend, right? I'm your professor. But sometimes they need that. Sometimes they are far from their family. I had one student, she said, can I just have a hug, Dr. Sampson? I was like, oh, okay. And I hugged her and she just held me. And I just was like, all right, this is too long, right? But she needed that at the moment, right? So sometimes the students, they are adults, but they need me to be a parent, but yet I have no children. Okay? But then they just need the support to understand that they can do it. One of our department assistants, she assigns every New Orleans student to me. Every New Orleans student. It took me 2 years to realize that. And so, but she did that because I'm a local. I understand what it's like when you have competing roles. You're the daughter or son, the granddaughter, the niece, the cousin, the coworker, your partner, and you got all these roles, including student, you have to do. And it can be very difficult that other students may not have without having that family or system that they came from home with here. So they have a little bit more freedom. And so I find that those students tend to take my word a little bit more. They yield to me a little bit more. They push in, keep going because I've been there. I know what it's like to go to school and live home, and you have all of these things happening, and life's just start lifing. So it's very important to have that community, regardless of what it is, and especially with your health, because if you don't have a trusted friend that you can open up to and say, hey, this is going on with me, I'm afraid to go to the doctor. Can you go with me? Well, can you go look it up or make a phone call or check things out? That's very important.
All right, so I'm going to say thank you so very much, Dr. Sampson. It's wonderful.